little bit fast, but a little bit slow at the same time, just so that we kind of walk around with everyone as we go together. One thing I'd like to point out initially is we started with exposure and, hello? Exposure and outcome. So, on the 2x2 table, we had a disease or the outcome on the columns, and then we had the exposure on the rows. Today, the exposure changes to test. Are we good? Changes to test. And we will try and work out slowly so that we kind of get to understand. What is an exposure? Yeah? Speak up. A risk factor. What's an outcome? Yeah? The event of interest. What's the test? We're coming to that. Hold the thought now. So, I'm not going to go through that, but when you get the slides, understand some concepts of screening and disease, understand some of how to evaluate a few things, know how to use multiple tests, interpret, multiple approaches for evaluation, and then some main features of some pooled specimens. So we have a lot of stuff to cover today. There I'm trying to structure the day is we do as much as we can until 10:30, or break is at 11? 10:30, okay. Up until 10:30, then I'm hoping we can spend the rest of the day, a good chunk of the day, kind of working through the codes and discussing the concepts. I think it may help in terms of understanding that as we move along. So that's the definition of a test. It's any device or a process. When you have a kid in the house and you touch the kid's face and you say the kid has a fever, is that a test? Is that a test? Yeah. When you eat some food and you say it's too salty, is that a test? So it's a process, right, by which we can define something. So it's a device or a process by which we can detect, quantify, or assign substance, tissue change, body response in an individual or a population. You have a stomachache, we can quantify that. You have a fever, we can quantify that. So you go and do a malaria test, it's positive. There's a reason why it's positive. It's measuring something within the body, like an antibody, right? You do a HIV test, it's measuring something. We do the COVID test, we know what it measures. So the range of diagnostic techniques is always very wide. It can be clinical, pathological, microbiological, biochemical, immunological, diagnostic imaging, including things like autopsies. Like a postmortem is a test. If you want to know whether you have an enlarged thyroid, postmortem will be the best, right? Because then we can see it. But will you do a postmortem, or will you do that in a living human being? No. So we will have to have a different test to use. So we can do, for instance, like a radiography. So in research, understanding the characteristic of a test is actually essential to knowing how they impact the quality of the data gathered. What does that mean? In research, understanding the characteristics of a test is essential to knowing how they impact the quality of the data gathered. What do you understand by that? It's not just a sentence to fill the slide. How will the test result affect the quality of the data gathered? And to make sure we are starting from some basics, and then now we start building complexity to Kisonga. Yeah. If the scale of that test is wrongly adjusted, then what happens? Can bring about measurement error. The other way of putting that in is if the test is imperfect, we may end up with imperfect results or misclassification of people, right? There's what we call screening tests. There's what we call a diagnostic test. How many people here worked in a lab? Purity. Who else? You know, mkono wacha woga. It's morning, like it's 8. Furnace. Remind me the name again, sorry. Yvonne. So Yvonne, when you say you're screening somebody for malaria, what are you doing?
You're testing for the presence of the parasite.
And then how will you know that that person has malaria?
So it will depend with the test, I'm
Uh-huh.
thinking.
Uh-huh.
For like microscopy, you'll be able to see, I can't remember the exact thing you're supposed to see on the microscope.
Okay. So the plasmodium.
Yes.
Uh-huh.
And maybe if it's a strip, like a diagnostic strip,
Mhm.
it will give you maybe like a positive, negative.
Okay.
Yeah.
Purity. Cool. Nakamoja, your question is coming. We are working on something. So, if you say you diagnosed George with malaria, what do you mean by that?
I mean that George is positive
For malaria.
of malaria. Yeah.
So, where do you draw the line between her screening for malaria and you diagnosing for malaria?
It's like a confirmatory.
Good.
Yeah.
That's the term I wanted, confirmatory. So we can do a screening of the population. Technically, it's always asymptomatics, right? You understand when I say asymptomatic? Eh? It's always asymptomatics. And then we want to do some kind of a confirmation. So we'll use a diagnostic test for confirmation. Now, where it gets confusing, a screening test can also be used as a diagnostic test. I want you to make sure that is very clear. So, the rest tutajisomea. Taka nikisonga tukienda, and then we get to a point where we can have the discussions as we move. So, we drew a 2x2 table, sindio? And we hammered that on Monday perfectly, right? Hello? Yes. It's asubuhi. Did you take coffee? No. It's provided for free. Like all you need to do is kigu na njia up to that point. So, when we talk about exposure or when we talk about a test, a 2x2 table, you understand how it came about, right? Why it's 2x2, sindio? We have a disease condition, positive or negative, and we have, for now, we are saying test, right? We are no longer using exposure for now. So we are looking at the test characteristics. So we also have a text categorization as positive and negative. Same way we reasoned through a 2x2 table. I don't want to belabor in this because I think we spent a lot of time kind of working through this. We have cell A, B, C, D, right? On the rows, we have the test. Test positive is A and B, right? Test negative is C and D. Disease is the columns. Disease positive A and C. Disease negative B and D. I've put in thing here about true prevalence and apparent prevalence. I think I shared this slide before, right? When you're discussing this, just to clear the stuff that is there. So the probability of testing of disease positive, the probability of disease test positive. So, we can shift questions. What's the probability of test negative? What is the probability, what is 1 minus probability of disease positive? Huh? Huh? Okay. I'll take that for now. We'll come and argue later. So, the usual problem is we know the status because of the test, right? We know the test result, right? But we don't know the actual true disease status. And that is because what we see is the result of the test. Now, solution is for each test, we can estimate some usefulness, the validity of the test and the true disease prevalence using 2 parameters. Number 1 is sensitivity. That is the proportion of diseased individuals who are test positive. I tend to use probability because I think it's easier to explain. The words are the proportion of diseased individuals who are test positive. So in other words, you are testing positive given you actually have the disease. A malaria strip, as Yvonne was putting it, will tell us the malaria is, George has malaria, right? But in actual sense, does he actually have malaria or is it having a cross reaction with something else? So the probability of a test positive given disease positive is sensitivity. And then the probability of testing negative given you actually don't have the disease. Disease negative is the specificity. Those two things are very important, especially when we think about how we interpret the test. Sensitivity is determined by using both non-positive animals. So let's say, for instance, we want to know what is the true. Does this test work properly? So we do like an experimental, right? Where we infect an animal, let's say, with Plasmodium knowlensi. So we are infecting primate. And then we use a test to actually show that the test is actually working perfectly well, right? Right? Let me introduce the concept as now, as we move around. When you're making that strip, it has already been validated in the lab, right? Using the non-positives. They do some serial dilutions. I'll come to that later. They do some serial dilution, and they identify what is the minimum, let's say, concentration titer that can yield a positive. Safi? We can also get it from definitive diagnosing using some other test. Or there's an antemortem test, because if I have tuberculosis and I'm dead, you can actually see tubercles in my lungs or find tubercles in different parts of the body. So, group of non-positives. I just added that just to show. Specificity basically is a group of non-negatives, e.g. from a disease-free area. We have a couple of vets here. Which countries don't have FMD? FMD is foot and mouth disease. Omar, which country does not have foot and mouth? AKA, which country can't you export your cows to? Because based on World Trade Organization, we cannot export an animal, or we have to be careful about diseases in certain area. UK is an example. New Zealand is another one. So if you want to test whether the tool we are using can detect a negative animal when in truth the animal does not have disease, we can use like a population from New Zealand, right? Yeah. So that's what I mean by that sentence. There's an inverse relationship between sensitivity and specificity. We discussed this, right? Where the trade-off, and we will come back to it again, where the trade-off between sensitivity, when you have a highly sensitive test, what could be the potential problem? I know it's low specificity. Stop looking for the shortest answer. When you have a high sensitivity test, what could be the problem? We talked about 2x2 tables. False positive. When you're a high specificity, and we will come into that. So if we increase the sensitivity, we decrease the specificity and vice versa. This is because the things we're measuring are the same, right? Within the body, it's an antibody. So if it's negative, it's negative. It's positive, it's positive. Now, a highly sensitive test means that there are very few false negatives. So, and thus, fewer actual cases of disease are missed. What is a false negative? Test is negative. The disease is? The disease is present. Why is that a problem in an eradication program or a control program? Let's use an example of HIV/AIDS. What would happen if the test is negative, but actually the person has the disease? What is the risk? Transmission. You're more likely to transmit, or more likely to miss a case within the population that we would have controlled potentially if we were able to detect it. You can use the example of TB, you can use the example of any other disease. If you're not able to detect TB, for instance, so your test is negative, and that is pretty common in things like tuberculosis because of how the disease immunologically operates. When you inhale TB, for instance, it goes into the lung, goes into the alveoli. Then what? It's foreign to the body, right? So when something is foreign to the body, the body reacts. The body does not react. The body is primed to react. The macrophages come, right? They are engulfing it. They produce what? Antigen presenting cells. Those go into the neutrophils and the rest, then the CD4, CD8s, right? When you're doing a test, a quantiferon test, you know quantiferon test, right? A gamma interferon. It's measuring one of those. So if you're going to use that particular test, you're more likely to identify exposure, right? Now, assume the disease is contained in the lung. It goes in the form of a tubercle, right? That's what you see as radiodense or radio differences areas within the lungs, right? That particular individual will, when they cough, they are not infectious. So they have what is known as latent tuberculosis. They are not infectious. If you're going to use a sputum test for this particular individual, and you're using an acid-fast stain, you will find a negative, right? But in actual sense, this person has tuberculosis. If you use a quantiferon test, you may actually be able to identify the, the antibodies, because we use the SAT6, early secreting antigen 6, or the CFP from what is have the quantiferon. The four tubes, which is TB1, TB2, nil, and mitogen. Those are used for that. Now, depending on the test we are using, in quantiferon, we might be able to identify an exposure. Why am I using the term exposure? The person may not have an active TB. So we might be able to say this person is positive, right? But then we need to think about, like, are they infectious? If we do a sputum test, that individual will become negative, right? But then the individual may be able to develop TB later in life based on immunosuppression and other things that come up. So that's what I mean by that thought process. A highly specific test means that there are very few false positive results. It may not be feasible to use a test with low specificity for screening, since many individuals without the disease will screen positives and potentially receive unnecessary diagnostic procedures. There's also the issue of costs when you're doing that. So we've just kind of discussed this. So what we mean by this basically is you have a criteria, right? Which is at what titer, let's say use titer. At what titer, for instance, you want to go into titer. Okay, we have a criterion whether on one side the individual is healthy, on another side the individual is with disease. Sorry, it's too light. With disease, without disease. This is negative, very clear. This is positive. Sorry about the colors. So you have a true positive, right? What is at the cutoff we want? If we increase specificity, then 100% everyone is negative. If we increase sensitivity, everyone is positive. So you have true negatives and you have true positives. But also within that, you have a false positive, which means amongst the true positives, there are some that are being classified as, and amongst the negative, some are being classified as false negatives. These are test negative, these are test positive. If X, test value, if X is less than C, which is the criterion, then the individual doesn't have the disease, right? So assume a cutoff where we say greater than 10, less than 10, right? So if this is 10, if this is 10 and X is less than C, then they don't have a disease. Greater than C, then they have a disease. So we use this basically, try and think about it. I'll come back to this later to discuss something else. I just wanted to introduce that at that point. So these are basically potential outcomes when you're doing screening tests with varying levels of sensitivity and specificity. So you have a test characteristic, which is a high sensitivity, increased number of true positives, identify people or individuals with the disease, high specificity, true negatives, identify people without the disease. So you're avoiding unnecessary treatment. Some of these things, they're not just theoretical concepts. You've heard of the issue with the Bruxelles test, right? And the high number of false positives. Why do you think that is? Why is the Bruxelles test bringing in a lot of false positives? Isn't? Is that what? Speak up loudly. Antibodies from previous exposures are still present. Okay. What else could be happening? It's a hypothetical question. Yeah, Donald. Is a screening test based on? Presence of antibodies. Okay, so it might be cross-reacting something else, right? Who remembers the Widal test? Who remembers the Widal test? What is a Widal test? Used to test for typhoid. Do we still use it? No. Why? Sorry? Speak. Some population almost everybody is getting a titers and they're ending up being treated for typhoid. How do you treat typhoid? Using antibiotics. So there's a problem there, right? If you're subjecting the population to unnecessary use of antibiotics, there's a cost that we're going to incur in terms of AMR, but also the actual cost. So some of these things, there are potential there. Potential harms of opposite test characteristics. Low sensitivity, increased number of false negatives, potential feature illness and suffering, potential feature spread. Low specificity, increased number of false positives, bodily harm, toxicity, financial cost, unnecessary treatment, social stigmatization, confidence in screening program. You can imagine if people were to discover that when you go for a HIV test, you're more likely to get a positive, but it's a false, what? Positive. You can imagine that will do to the program in the country in terms of disease control. Same with things like TB, same with things with other diseases. So there's implications for this. We discussed predictive values, right? Right? Mmesahau kidogo. So let's work around it. So we have, so what is a gold standard? Just kizungu tu, tuanzie kizungu. We normally start from what we know, then we go to what we don't know. That's the typical about life. So what is a gold standard? When you say a gold standard? Sorry? The best or a reference. Sindio? The best or a reference. So we have those tests that are considered a gold standard. If I'm going to look for the molecular of a disease, then I can use a specific, right? And if I find a positive molecular test, then I can say that will be a gold standard, right? So if I'm doing TB and I'm able to actually identify sequences and get sequences for Mycobacterium tuberculosis or Mycobacterium capreae or Mycobacterium bovis or Mycobacterium caneti or Mycobacterium africanum, whichever, then I can say for sure that is a test. Then I can use a separate test, right? So that is a gold standard. So we are able to classify as disease positive or disease negative. Then we have a screening test. We have defined a screening test, right? So now we can differentiate between a gold standard test and a screening test. So in a screening test, we also end up with a positive and a negative. Based on a 2x2 table between the gold standard test, please do note here is the disease, but we are using test, right? So bring your mind into the test. So we are going to evaluate the test characteristics. So based on a 2x2 table between a gold standard and a screening test, we have a 2x2 table. A true positive, a false positive, false negative, a true negative, okay? This column here determines the sensitivity. That is the column for the disease positive, if you want to call it that. So the test positive according to the gold standard. This column here determines the specificity. This column here for testing positive determines the positive predictive value. This column here determines the negative predictive value. Let's rework that a little bit. I'm using these as a sample type, target, non-target, but basically use these as disease positive, disease negative, a response positive, negative. Sensitivity is true positives divided by true positives plus false negatives. What is true positives plus false negatives? Sorry? A plus C. Give me in the form of a probability, because I think that will allow you to think about what that means. So that is the probability of what? test positive, given? Sorry? Given the disease is positive. So the first letter, you look at the cell. The second one, you go to the row that represents, or the column that represents that. Safi? Probability of test positive given, disease positive. We will come back to the probability. I know yesterday I asked a question and nobody answered. We are going to come back to it later. And then we have a specificity, which is basically the number of true negatives, right? Divided by both the true negative and the false positives. We have a positive predictive value of a test. What is that? Use English and then we use epidemiology. What is a predictive value? What is prediction? Foresee. So when we think about a test, when you go to a doctor, so Yvonne said she can use a strip, right? And it has malaria, testing for malaria, right? And then I go to Ricky and I ask Ricky, or Ricky gets the test results of the doctor. If I have a positive test, please follow my thought. If I have a positive test, how likely am I to actually have the disease? You follow the thought? If I have a positive test, how likely am I to actually have the disease? If I have a negative test, how likely am I not to have? Clear about that? So the positive predictive value of a test is actually an indicator of, in a positive test, how likely are those results within those who have tested have the disease. So true positive divided by true positive plus false positive. On the contrary, true negative plus false negative. Then there's something called accuracy. We'll define it later. But basically, accuracy tells you how accurate are those results. So in this table, which are the accurate cells? A and D. What is A? What is D? So those are the most accurate results, right? But then you want to kind of find it a proportion divided by the total. You get the kind of the reasoning out. I'll come and reason later as we move. I just want to kind of introduce a few concepts as we go around. So we are interpreting a test with non-sensitivity and specificity. So let's assume that a test has true positive rate, or true positives of 90, false positive of 45, 10, false negatives, and then true negatives of 85. So the prevalence, these are just numbers we're giving. So 10% sensitivity 90, specificity 90. So this is basically a good serologic test. You remember the sensitivity definition, right? And remember the specificity definition. So what is the probability that a test positive animal has the disease? We are calculating what? The positive predictive value of the disease, right? We are giving it as 90 over 135. So it is, you remember the true positives divided by true positive plus negative predictive value okay. The probability of having the disease given the result of a test is known as the predictive value. Basically, the predictive value of a positive test is how likely are you, given a positive test, to actually have the disease. These are important concepts that we're going to kind of a little bit delve into because there are differences in terms of how we think about them. So I'm going to pose a few questions so that we kind of go back into the AP as we think about. Would the prevalence of a disease in a population affect sensitivity? Will the prevalence, the actual prevalence of the disease in the population affect sensitivity? Any reason? Speak. Antibody. Huh? Antibodies. Explain. You can't just wake up and say, Uhuru. What has happened to Uhuru anyway? So I want us to reason. As much as we're kind of putting the slides there, I want us, remember we are building a class from Monday to Friday, right? So I want you to remember the concepts that have been put out there. So what would make the prevalence of a disease within a population affect the sensitivity? They can't hear you.
So you say that the prevalence I think I'm loud enough. So we've said that prevalence is the condition of the disease in a population, and some of the condition
The number of individuals with the outcome of
interest. So, and that can be sometimes based on antibody levels, and maybe some of the tests can pick instead of the how do you call it? Can pick IgG instead of IgM.
you're digging yourself into a hole.
So if the prevalence of the disease is high, I think you're most likely to test the positive cases, and the probability of you getting a negative case will be low. So that means you will wrongly classify the screening test as positive. I mean, to have a high sensitivity.
Okay. Hold the microphone for a minute. So let's discuss first the relationship between a predictive value and the prevalence, right? Here the prevalence is what? Here the prevalence is what? When we do the calculation of predictive value positive is 85.9, negative is 96 point, based on a 25% prevalence. So this is predictive value. So here the predictive value is 10. What is the predictive value here? 90 over? Which is what? I want you to do it by hand so that we wake up. 60? And the NPV? The NPV is what and over what? 855 over 865. Good. Is what? 80? 99. So this is at 10% prevalence, right? So at 25% prevalence, the positive predictive value is 86%. At 10%, it is. So when we have the reduction in the prevalence, the PPV reduces. At 25%, the NPV is 97%. It is 99%. Any thoughts about what's happening? I want you to think of like a disease eradication program. Mm-hmm. What is the definition of a positive predictive value of a test? Go back to that, and then now we reason from that as we move through. No, you didn't get it wrong. I just want to refine the answer. There are things I'm trying to communicate. So it's not like you got it wrong. Which human disease are we targeting for eradication next? Hello? What? Polio. What is the prevalence of polio in Kenya right now? Hello, hello? I thought all of you work in the health sector. I had a chimpanzee with polio in Olpejeta called Judy. She has a withered left leg. What is the prevalence of polio? Okay, let me walk you through my thought process. How are we controlling polio? Through vaccination. Good. How do we test for polio? Huh? Using what? Stool samples. What do we do to the stool samples? Sorry? Viral isolation. Okay. So, let's assume the prevalence is 25%. So, at the start of our hypothetical program for eradication. So, are we likely to see more cases when it's 25% or when it's 10%? It's 25%. So, it's not a trick question. It's just a scale, upper to upper. So when you have a higher prevalence of a disease within a population, you're also most likely to see the cases go up. So then that means also the potential for you testing positive given that you have the disease is high. So when the disease, you've done a good chunk of eradication, you've worked on the sewers, you've checked some of the areas like Isili, the prevalence goes down to 10%. The chances of you testing positive, given that you have the disease, are also lower. But the chances of you testing negative, given you don't have the disease, are higher. So there's kind of a trade-off, especially when you think about it, and we think about like an eradication program, where we now need to shift into choosing a test based on the specificity and the sensitivity. So, now, are we clear with the first point? Does it make sense? Now, as we move along, I'll show you a slide. I just want you to do this concept so that when we go through the slide, we're not repeating each other over the same things. As we move from an eradication program, we are starting from a point to the last point of the thing. Which disease was eradicated in 2010? Which disease was eradicated in 2010? Which disease in the world was eradicated in 2010? Rinderpest. How many know rinderpest? It belongs to which family? So that we can help the others who are not vets. Belongs to which family? Okay, it's related to which disease in humans? Huh? Measles. Measles belong to which group? You're not just learning epi, there are things you're going to apply it into. I was talking to Brian, I was telling him there's a combination. Yeah? Herpes virus. Hey, my friend. Boru. Herpes virus. Herpes viridae. Measles is part of which group? Kimomana. Anyway, they are kind of related. It's the same as we have cowpox and we have smallpox. We normally have diseases migrating, or not migrating, diseases transmission between animals and humans. And sometimes you can control one disease using another. How many know Edward Jenner? How many know Jenner? The story of smallpox and the story of cowpox? The origin of vaccination? People who are working with cows were less likely to get what? Okay. So as we move through an education program and our prevalence becomes low, it means we need to use a test that is what? Highly specific or highly sensitive? Please think before you answer that question. So we have just discussed predictive values of a test and how it changes with the prevalence, right? Now, at the tail end of our education program, let's say the prevalence goes down to 1%. of polio, right? So are we supposed to use a highly sensitive test or a highly specific test? Explain. Yeah. So when you use a highly specific test, what does that mean? Mhm. So the prevalence goes down to 1%. So I'm following the slides from 25% to 10% to 1%. At 1%, the predictive value of the test goes down to 15%. The predictive value negative goes to 99%. So think about what happens to the false positives and the false negatives as the prevalence declines. So we go back to our previous slide. Look at the false positives and the false negatives as the prevalence declines. At 25% prevalence, we have a false positive of 37 and a false negative of 25. At 10%, the false positive is? The false negative is? Why? Remember, sensitivity of our test is 90 and the specificity is 95%. I need this concept hammered in, then now we can rush through. Why? What is happening? When a test has a high sensitivity, what could be the problem? You get more false what? Creases. You get more of what? Positives. Are we seeing something similar to that here? So, when we move to 1% and we keep the same sensitivity and specificity, we're getting high. Is that a problem? If you have a higher number of false positives, is that a problem? Yes. Why? In epidemiology, one of the best answers you can ever give is, it depends. Okay, let's start. So, having a high number of false positives, is it a problem? Yes. Who has said yes? Uh-huh. You have a microphone hata mbele yako. Uh-huh.
I'm thinking about it in terms of the stigma of being diagnosed positive and also being initiated on unnecessary treatment.
Perfect. That's a good answer. I said in epidemiology, you said the answer, it depends. What if it's an eradication program?
In that case, I think it's no, because for them, they just have to make sure the true positives are 0. So if it's a false positive, the person doesn't have the disease, it means that they don't have the disease either way. So in an eradication program, to them, there would just be 9 people with the disease. Even though there are 59, in reality, there are only 9 people, so they're achieving their goal. So, yeah, in that sense, maybe it won't.
Okay. Let me, sorry? Let's, I know we are going, there's a slide for that. Now, let's assume it is the other way around, where we have higher number of false negatives. Will that be a problem? Okay. Yes. Who said yes? Faiza. What problem will that pose?
So if we have many false negatives, that means that we'll be missing some true cases. Yeah.
Yes. So we'll be missing some potential true cases, which means we have, the disease remaining within the population. So this is where when you talk about test characteristics, they're very important. Typically, we will use sensitivity, specificity, and then we will use predictive values. So the predictive values within a population does change depending on the prevalence of the disease in the population. The predictive value is the answer to the question, if my patient's test result is positive, what are the chances that my patient does have the disease? Predictive value is determined by sensitivity and specificity of the test and the prevalence of the disease in the population being tested. Have we demonstrated that? Did you follow? We held constant the sensitivity and specificity and then shifted the prevalence. And you can see if we start shifting to a highly specific or a highly sensitive test, that does shift. The more specific, the more sensitive the test, the less likely an individual, please note, the more sensitive the test, the less likely an individual with a negative test will have the disease. And thus, the greater the negative, please note this particular part. The more sensitive a test, the less likely an individual with a negative test will have the disease. Thus, the greater the negative predictive value. Understandable? The more specific the test, the less likely that an individual with a positive test will be free from the disease. Thus, greater the PV. Make sense now? You're good? Those who are keeping quiet, are we on the same boat? Amma, you went into the noise one. Oh, Brian, yes. You just? I thought you were Brian.
My question.
Yes, yes.
Just asking question out of curiosity.
Okay.
Like there is this two setup. Maybe targeting disease that are actually vaccinated. Let's say one for COVID and
Yes.
another for measles. So for measles, let me say maybe you develop herd immunity after vaccination. Maybe the population actually develops herd immunity because when you're vaccinated, you might not get the disease again, maybe. That's my take. But for COVID, there is this essence of once vaccinated, you can still contact the disease when the disease is still in circulation. So if by any chance you are a public health officer and you are now trying to determine maybe how well you can eradicate or how well you can actually comment on the prevalence of that disease in that closed population. Because in one area, you remove it, it does not come back. In another area, there is chances that it might come back. So in terms of specificity and sensitivity, how can you explain that concept?
Okay, good question. I'll answer it in multiple formats. Number one, a vaccine can be used to control a disease. So, in some circumstances where we have, like in the rinderpest vaccine, in the smallpox vaccine, I think in the late 80s, where we knew once you get vaccinated, you're not likely to get the disease. We know you can control it. Now, in the case of something like a COVID vaccine, the vaccines are not supposed to completely prevent the disease. We're supposed to prevent the severity of the disease. So, when we start talking about the test versus, so the vaccine is not a test per se, but you can assume it as a condition in terms of preventing, not preventing. So, and you can still create a 2x2 table and reason through it within that. Now, what is herd immunity? Strong immunity, according to Purity. What is herd immunity? Population level immunity. In this room, give or take, we are like 30, let's say 30 people. So, if we vaccinate 10 people in this room and disease X comes, let's say the vaccine can work perfectly, so we vaccinate 10 people, then the level of vaccination in this room is 10 over 30. And to make a very basic argument, so then that means we still have 20 people who are susceptible, so, and can still get the infection and transmit it around. Now, what would happen if we move the vaccination level to 25 out of 30? The potential for the susceptibles goes down, and so we're actually able to try and control the disease. But remember, we are still not, we have not vaccinated everybody, but we are able to provide, those who are vaccinated are able to provide immunity to the unvaccinated. That is the concept of herd immunity. Now, in the morning around 7 when he came here, we were discussing with him about kind of, it's a different thing, but let me just explain it. How vaccines, especially in circumstances like COVID, where when they don't work effectively and there's what is known as antigenic pressure within populations, what that may mean. What that may mean. Let me just use this slide in 1 minute without discussing. Those who want to discuss can discuss later. I use this when I'm teaching immunity and stuff like that. This is a disease known as PRRS. Porcine, ngetich, iravet. Porcine, reproductive. Where? Hey, my friend. Porcine respiratory and reproductive syndrome virus. Now, this is data from the University of Minnesota Veterinary Diagnostic Lab, where a gentleman known as Bob Morrison was collecting this over time. So what we did was basically we plotted it. Now, it has lineages. Think of, in your mind, put in like COVID. So I just want to take a minute just to explain what it's saying so that you understand how it can be different in terms of stuff, but then we can play around with it. What you're seeing here is you have different lineages, but in 2009, one of the predominant lineages was 9, right? But you still had, as you move along, you have green coming in, 1C, but you still have the reds coming 1B, but you also have lineage 5 around, right? As you move to around 2014, which lineage is that? Type 1, right? Takes over. So, why do you think that is happening? We only have a minute and then we go back to the normal thing. Why do you think that is happening? So think about COVID. Mutation, that's one thing. What is leading to mutation? Sorry? Think of viral evolution. What is leading to mutation? Hello? What in the body? The virus is in the body, so obviously it's something in the body that is leading to. Think of COVID. What pressure? Sorry? Selective pressure. Let's call it that. There's antigenic pressure, there's kind of the evolutionary side of it. So what is happening is there's something within the body that is happening, either immunological changes or immunodynamics, as you call them. What exterior thing can lead to an internal immunologic pressure within the body? What exterior thing can lead to internal immunodynamics changes? Vaccination. So another way of showing that particular slide is that. And what you see here, you remember lineage type 1, which came in 2014 and became the predominant one? You remember the initial lineages that were there in 2009? But think about this, the stars. The stars are vaccine and prototypes. You have vaccines where they're being introduced. And at the moment, what normally happens is when we're using a serotype or some kind of a strain-specific vaccine, we're inducing pressure against that particular lineage or strain, right? And then that leads to an emergence of another one because they are all these competing immunodynamics. Remember, the structure of a protein is very complicated. So when you're thinking about specificity and sensitivity, in terms of that, there's need to combine that. It's just not the only thing you're thinking about. There's need to kind of evaluate what are we trying to achieve with this program. The initialization of like the COVID vaccine was because our healthcare system across the world was being burdened. Our economies were going down there was need to provide a proof, a relief. And the relief came in the context of vaccination. And that led to a little bit creating some level of immunity such that even though you may subsequently still get the disease, it will not be as severe as it was initially. So the way we reason from that and the way we will reason about controlling a disease is slightly different in terms of thought processes. Are we good up to there? We can go back to screening and diagnostic tests. You can join Fanny's in the molecular lab at Ahil, at Kabete, and you'll get more of this. We were there. So when the prevalence is low, the positive predictive value will also be. When the prevalence is low, the positive predictive value will also be. We explained that, right? And you can get that. Even using a test with a high sensitivity and a high specificity. For such a large proportion of those with a positive screening test will inevitably be found out to be not having the disease. To increase the positive predictive value of a screening test, a program could target screening those with high risks. For instance, demographics. So those who work in the hospital here, what age group of women are mainly told to go for mammograms? 35 and above, 40 and above, right? Why? Because they are at a higher risk. So you're more likely, you're increasing the positive predictive value. Because the prevalence of the disease within that particular age group is, that is how we reason through these diagnostic tests. Occupation, mammogram for MB40 and stuff. The implications for surveillance basically means, number one, as the program decreases the disease prevalence, many individuals who are truly disease-free are classified as disease-positive by the test. So that is the increase in the number of false positives. This is a big problem depending on the objectives. When will having a high sensitivity or specificity desirable? Which one is more costly? We have discussed that, right? How high values of sensitivity or specificity are acceptable? This depends on the disease under study, implications for incorrect diagnosis, ease and cost that Maureen was talking about. High sensitive tool could be used to rule out the disease in question because there's a high chance that the tool gives a positive result when the disease is present, and the tool gives a negative result when the chances of the disease are nil. For screening, in later stages of a disease eradication program, you change from using a highly sensitive test to a highly specific test. So you're trying to increase the negative predictive value. That is why I'm introducing those topics when I move. You're shifting from a highly sensitive test to reduce the number of false positives to a highly specific test to increase the negative predictive value of a test, which means the likelihood that the individual who tested negative not having the disease are high. However, if the aim is eradication, a highly specific test leads to more false negatives, which have implications if you leave a diseased individual within the population, right? So if the aim is eradication, we better risk having a higher number of false positives, because then we are capturing all that are positive plus some that may not be positive, but then we are able to capture all the disease within the population. Okay. The other way of increasing the predictive values can be changing the critical titer. So if, let's say, actually, where's the microphone? Faiza, last week you were in ILRI doing Crimean Congo hemorrhagic fever testing. Can you explain what you guys did so that I use that as an example? She was there with a lady called Annie Cook. She's my master's student.
Okay. What we are doing, we were doing seroprevalence.
What is seroprevalence?
We're checking for the presence of antibodies against the virus I was looking at. So we're checking if we have the antibodies against that virus in the samples that I was testing. Mm-hmm. So I was doing an ELISA test.
What is an ELISA test? There's something I'm driving at with the title.
So ELISA test we're looking for the antibodies in the samples.
So you're basically having some specific measurement that you're
Yes,
using,
yes,
using a what? Spectrophotometry, right?
yes, yes.
And then you get some kind of you develop some
The
kind of a
value.
cutoff.
Yeah,
If it's above a certain cutoff, what was your cutoff?
cutoff was 30%.
30%.
Yes.
30% of what? It was 0.3
Yes,
on the spectrophotometry.
Yes.
So if it was above 30, it was considered
positive.
positive. If it was under 30, it was
was
considered
negative.
negative. Now, let's do a thought process. What happens if we reduce the cutoff? You remember that's the critical titer, right? So what happens if we reduce the titer? So let's assume we tested 100 samples. So more than 0.3 was 50. So less than was 50. So what happens if we reduce the titer to 0.2? What's going to happen to this classification?
It's going to have more.
We are increasing the positive.
Yes.
Sawa. You get the thought? So we can reduce the titer, critical titer, to 0.2, which means our definition of positive is considered severe. Sawa. We can do that with eradication. We do that with the eradication program for things like bovine tuberculosis and a few other diseases, especially in the livestock and wildlife sector. So you can reduce the critical titer, and that means you have a lot more positive animals, sawa, or positive individuals. You are increasing the what? The predictive value. When you increase that, you're increasing the positive predictive value, which means the probability that the individual tested positive, given that they have a disease, is high. Perfect. You can use additional tests. When you go for HIV test today, I walk into KNH, they'll do a pin, right? And then if I'm negative, they'll tell me go home. Why? I want you to reason from the class. If I go for HIV test today, I'll walk into KNH, they'll do the counseling, they'll do a prick, then they'll tell me you're negative, go home. Why are they not subjecting me to a second test? Use the appropriate term. We have just learned it now. The negative predictive value is high. That is why when you get a negative test, they tell you you're okay, go home. But when you get a positive test, they subject you to a second test. Not a confirmatory, a second test. Why are they subjecting you to second test? They want to increase the positive predictive value of the testing program. That's the reasoning behind all this. So when you use an additional test, two things can happen. The person who was positive or the individual who was positive on the first test gets only the individuals who are positive on the first test get subjected to a second test. That is scenario number one. Scenario number two, everybody gets subjected to a second test. Now, we reason. Leo tuta reason tukisonga. Fike mahali sasa watu waanze kulala. So, test 1, test 2. Sawa. This is positive, so you get to positive. Sawa. So scenario 1 is only those who are positive get subjected to. In scenario 2, everybody. That includes those who are positive and those who are negative. Sawa. The end result is they can be positive here, and they can be positive here, right? Or they can be negative here and negative here. If this person is positive in the first test and was subjected to a second test and they're positive, they'll be considered positive. So, this is, go back to the slide. This is what we know as series testing. So, where positive animals, when I say animals, I call individuals. I'm a vet, so I'm biased towards animals. To the first test, as tested using a second test, only animals positive to both tests are considered positive. So there's what is known as a series interpretation or a series testing. So, testing in series, like the physics, battery. Those of us who did physics in high school. Series you connect, parallel, nasongesha. Now, series testing, please take note. only those who are positive in the first test are subjected to a second test. It's sequential. You're saving on cost, but giving the same results simultaneously. In this other one, scenario 2, so this is scenario 1. In scenario 2, we call it parallel testing or parallel interpretation. It means an animal or an individual positive to either one or both tests is considered what? Positive. So this would be positive, this would be positive, this will be, and if there's a plus here and a minus here, this will still be. So in parallel interpretation, any individual who is positive to one or both tests is considered positive. Brian, your brother. So, if our aim, let me explain something kidogo tu hapa. So, number one, we are improving predictive value. So, our aim is to improve the predictive value. And we know there's a positive predictive value, which means the probability of testing positive given disease positive. And then there's negative predictive value, probability of testing negative given your disease negative. Now, to improve, we can change the titer. You remember the Pfizer example? 0.3, we can reduce it to 0.2. So then we make it a severe interpretation, and we can compare that with the standard interpretation. So standard is 0.3, severe is 0.2. Which one improves? We are improving the what? Positive predictive value, because then we're capturing more positives. The likelihood, the probability of T positive given D positive. Now, second way, we can use an additional test. Additional test can be used in two ways. Those who are positive on the first test get subjected to a second test. The sensitivity of a program, the predictive value of a program. A HIV test, as I gave an example, when you're negative, you're told to go home because that test has a very high negative predictive value, which means it was used in a population that has a lower prevalence of HIV. You get how we are operating back and forth. Now, but when you test positive, so that they are sure, so in other words, they want to increase the positive predictive value, they subject you to a second test, a confirmatory test, which is normally different from the first test. So they're increasing the positive predictive value of the testing program. Tuko sawa mpaka hapo? So, and we can interpret that as only those who are positive to the first get the second one, series interpreted. The animal has to be positive, or the individual has to be positive to both tests. Note, on the other side, which is the lower part, if the aim is to reduce the number of false negative, we increase the sensitivity. So the other one is parallel, simultaneous. Those who are considered positive on one or either test are considered positive. What are we increasing there? Sorry? When you do a parallel test, what are you increasing? Hello. Nataka kuongea na Marco. Huh? You're increasing sensitivity. Now, we have examples here. We have early stage of a true prevalence is 10%. So, we are using two tests for brucella eradication in animals. A tube agglutination test, sensitivity 92, specificity 95. It's a very inexpensive test. CFT, a complement fixation test, sensitivity 90, specificity that. 10% difference. Now, we have brucella. So I just want to walk you through this. Apparent prevalence is prevalence of testing. Positive. Prevalence, true prevalence is prevalence of disease. Positive. Disease, P positive. Probability testing positive is apparent. So apparent prevalence is testing positive. Sawa is what? 13,700 divided by total. Safi? Predictive value positive. 92 over Predictive value negative 85,500 over comes to 67 and 99. Safi? Aya. In the later stages, 1%. Sawa sawa? Go back to the previous slide. False positives ni ngapi? When it's 0.1%, the false positive go to, no, this one. 5,097. So, with an apparent prevalence, we can calculate predictive value. Remember, 0.1. The predictive value is 1.8. It has gone very low. Compared to the other one, it was what? 67. Now, predictive value negative goes very high. Prevalence is low. Remember that. Now, if we are to slaughter these cows, we will slaughter this number of animals. Sawa. Because they're the one that tested positive. Sawa. Now, that becomes a problem if you're going to compensate. If we slaughter 5,097 camel, we only have 92 that have brucella. Where are we getting the 92? The true positives. So the true positives are 92. The false positives are 4,995. But now, our total that we see when you're going to give it to Omar as the in charge. Yeah, there. So there'll be complaints, right? And there'll be cost issues. But we have missed 8. 8 as what? False negatives. False negative. This is why the 2 by 2 table I said we're going to use it until the end of this week. The false negatives are, so we have missed 8. If it's an infectious disease, that is a problem. So, this is bad if you plan to eradicate. So, which is the biggest problem? That is the conundrum that, Brian, when you ask about what does a public health professional do, when we start reasoning based on the disease and the context, we have to kind of sit down. That's why you, as the epidemiologist, will have to come up with scenarios. So, we'll have to come up with scenarios for what does this mean? How can we work through this? When we talk about positive prediction, okay, I don't want to go into that. I'll confuse you. So, we could modify our testing by either series testing. Series testing is where? Hey, crisis. Okay, you are explaining. Good. And parallel testing? Funnies? Fast testing and the interpretation? And the interpretation? On one test or both, they are considered positive. Safi? So, we did a TAT, the tube agglutination. So, and we got our results. Now we are doing a CFT, complement filtration test. The biggest problem is false positives. We test in series. Take note, if the biggest problem is false positives, we test in series. We are increasing the specificity. In series is positive goes to positive. Nakumbuka? By that we are increasing the specificity. It's counterintuitive, but think about it. We are increasing the specificity of the testing program so that we know those who are negative are truly negative. We could use a CFT where now, remember our total population now that we are subjecting to the second test is those who tested. So the total is 5,087. So then, when we do the test, remember, now, kumbuka, we are using a second test. So, CFT. The first test was TAT. So now, we have 83 true positives, 100 as false positives, 9 as false negatives, and then we have true negatives as 4,800. Recall the prevalence is 0.1. So, the overall performance of this particular test, of the test, we have, remember it's those who are TAT positive. So that's why we don't have a place where we are considering a different thing here. That's why we have a positive, positive, negative as the likely outcomes. For TAT, this is the first test. And then now, on the second test, we have a positive, negative, negative. Depending on how, so this is the second test. If we test in series, we are increasing the specificity. In other words, we are sure that those who are negative are actually. So, interpretation, we have 83 being, so this is in parallel testing, for instance. We can say 83 are positive. 9, 8. So how many will be considered positive total when you test in parallel? 90? 90? Which is what plus what? 83 plus 9. Perfect. This is an example of a what table? A 2 by 2 by? Perfect. Now you see what Monday come back to today. So it's an example of a 2 by 2 by 2 table. So the apparent prevalence here is the total number who are positive, which is? So just the positive ones. So it's 183 over total population of the animals we had in the program. So the positive predictive value, 83 over overall sensitivity is 83 over 100. Specificity is the total number that tested negative, over the population. Now, the next part, using CFT, we have saved 4,895 individuals, animals. How are we getting that? True negatives. So we will consider negative as wait. If the biggest problem is false negative, we test in parallel. So interpretation of series versus parallel, we increase the sensitivity. So remember that. So when you test in series, you are sure that those who are negative are actually negative. So you're increasing the specificity of the program. When you test in parallel, which means any or, either or is positive, you're basically trying to increase the sensitivity. So the next few slides are basically just explanation of that same concept that we've just gone through. Another 2 by 2 by 2, where we are interpreting in parallel, right? In parallel, remember we have positive, 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 negative, negative, negative. So all the potential outcomes. So in series testing, we actually have the first test and then subjected to the second test. And our interest is only those who test positive on both. On both, in series testing. Yeah. On both. So here, to finish up with this, we know the apparent prevalence, which is the probability of testing positive. We want to know the true prevalence, which is the probability of disease positive. So although we have assumed the true prevalence is known, it is usually not known. We usually only know the number of test positives, which is the apparent prevalence. If we know the sensitivity of the test, in other words, the test was conducted in a maybe experimentally infected groups or a specific group that we know has the disease, or specificity of the test, where the test was conducted in a place where there is no disease or the prevalence is very low, so we are very sure that the negative is a negative. We can calculate the true prevalence from the apparent prevalence using, hold your breath. It's a long formula. We'll work on it later on. It's an apparent prevalence minus, what is apparent prevalence? Probability of test positive, right? Probability of test positive is A plus B over N. So, same as writing A plus B over N minus 1 minus specificity divided by a very long thing here. We'll come back to it later on after that. But there's a formula. I just wanted to throw it there because we always put it there. Okay. Our break is 10:30 or 10? Yes. Microphone copy. Oh, sorry.
What informs you whether to use serial or parallel?
What informs you whether to use serial or parallel? When you use series or serial, what are you increasing? What are you increasing? Specificity. When you use parallel, you're increasing? When would you want your program to have a high specificity? Think of the eradication program as a good example, as a thought process. When would you want your program to have a high specificity? When the prevalence, when the prevalence is low. When the prevalence is low. So, depending on the context. That's why I say in epidemiology it depends. So, look at it this way. When the prevalence is very low, if the aim is eradication, the risk of a false negative is more costly, right? When the prevalence is low, the risk, and towards the end of a program, the risk of a false negative is more costly because you're still leaving diseased individuals within the population, right? And so in that particular instance, you better risk false positives. So what do? You test in parallel to increase the sensitivity. Yeah.
I'll use malaria surveillance as a case example.
Okay.
When you go to Lake Region, there is high positive predictive value for malaria. Then now when you come to the highlands like Central, it is a bit low.
Yeah.
So in such instance, you'll be deploying different set of testing strategy. Yeah.
Testing strategy.
Okay.
So remember, there's the testing and there's the strategy. So in a program for HIV control in this country, we subject you to an initial test that has a very high NPV, right? So we know if you're negative, you're negative. But now we want to increase the sensitivity of that particular program, so the specificity of that particular program. So we test you in series. Those who are positive on the first test get subjected to a second confirmatory test. That increases the specificity of the program. In other words, those who are truly negative are negative. Safi?
Yeah. Thank you.
Okay. Any question? Break ni 10 ama 10:30? 10:30. Mwema, break ni 10 ama 10:30? 10:30. Okay, sir, cool. Okay. I think I can hammer that. Remind me your name.
My name is Purity.
Purity, okay.
Okay, let's say, for instance, like the test of IgG and IgM, moja ni series, ingine ni parallel, sindio? Sababu zenye unapatanga positive kwa IgG ndio unaendanga kwa IgM. What if now if you only have a series test and you had doubtful results, even in the series ones? Yes.
Good question. So she's asking about a doubtful, right? Let's go back to Pfizer's example. You remember the 0.3 greater and the 0.3 less, right? Anything above 0.3 is considered positive. So anything below is considered negative. Now, how do we improve the sensitivity of our test? We can reduce the tighter cutoff. So in a doubtful result, I'm assuming here we are doing a lab test. So in a doubtful result, we can actually do what is known as either a severe interpretation of the test or a standard interpretation of the test. In this, a standard interpretation would be anything above 0.3 is positive. A severe interpretation is anything above 0.2 is positive. Same way, you might not have the cutoffs for spectrophotometry measures. So we will say looking for the term, there's a positive, negative, and let's say doubtful, there's a term they use. Indeterminate. So we will say, to increase the sensitivity of our program, we will say any indeterminate and any positive is considered positive. Napata? This is research. Like when you do research, if I'm going to do bovine tuberculosis and I'm using gamma interferon, which is a quantiferon, quantiferon, which is a gamma interferon based, gamma interferon comes from CD4 cells, when you go down the cascade. Now, if I'm going to use that, then I'm using a cutoff. I can interpret it as any that is indeterminate and positive are considered positive. That increases the sensitivity of my program. So, because then I'm catching more false positives, but I'm getting a better sensitivity measure. So, if my aim is very specific, then I'll say any indeterminate and negatives are negatives. So, means I capture more false negatives, increases the specificity of my program, because maybe the indeterminate are actually truly negatives. So that's how we play around with specificity, sensitivities, and when we do that, we're also shifting the predictive value test. Because then if I say all the indeterminates and the positives are positive, then am I really sure that a test positive animal does actually have the disease? I'm not. There's a doubtfulness. So the same way, if I say all the indeterminates and the negatives are negative, then am I sure that the probability of testing negative, given your disease negative, is actually something that I'm looking forward to? Not really. So it changes both, but it depends on the aim. Sometimes we use both when we are doing like sensitivity specific calculations. I'll show you at the end of this next part what that means. Safi? We are good? You're tired? You want to stretch? All right, let's stand up for a minute. Mutono is not here. She does a very interesting dance. I don't know how to do it. So my aim was to hammer these two sections. To Malize, when you go for tea, when you come back, we can play around with the code as we use different explanations until the time when we feel like we are tired of being near Thumbi. And you can go. You guys are good? Sawa. So, hatujamaliza bado? Hatujamaliza? So if you're to be asked today that you have a test, what measures can you use to describe that test? One, sensitivity, which is what? You're an epidemiologist. You don't just throw a word out there. Is what? Sorry, say that again? Proportion of the diseased individuals who? There's a reason I'm asking this question. Okay. So you said probability of is the proportion of diseased given they tested. There's a reason why I want you to master that. There's a reason I want to master that. Because the predictive value positive of a test is the probability of testing positive given your disease. Please take note of that. Please take note of that. That is a very interesting, important concept for us to understand. The probability of being disease positive given you have a positive test is the sensitivity. So, however, the test characteristic, positive predictive value positive, is the probability of the test being positive given that your disease positive. Please take really good note of that. And then, specificity is what? Probability of? Sorry? It increases. Disease negative? Yes, Purity? given that you're testing, and the negative predictive value of, let me say positive PPV negative is equals to the probability of testing negative given disease negative. And the prevalence is equals to probability of disease. This is true. What about apparent? Probability of testing. Please take note of that. It's pretty important when we are discussing the test, when you as a researcher or you as the person who is in charge of public health policy is trying to think about some of this stuff. The predictive value of the test can be changed using sensitivity, specificity of the test, and the prevalence of the disease in the population. So, because where I'm going next is a little bit tricky. So I'm trying to lay the foundation vizuri. So, the test, we are interested in the test being positive. So in other words, if I say somebody has tuberculosis, I want that test to actually measure what is in the body as tuberculosis. A sputum test measures what? A sputum with an acid test measures what? The presence of the mycobacterium in the sputum, right? And that is something that I can say is good. The problem with that is it has a very low what? Sensitivity. Why? Because there's potential human error. There's potential for how we are staining. There's a lot of potential errors, but also how we identify. So, when I use an ELISpot, how many know an ELISpot? How many know quantiferon gamma? How many heard of quantiferon? When you take the tubes, so you take blood in a tube and then you shake and then you incubate for 16 hours. What is that called? What test is that called? Quantiferon. It's measuring the gamma interferon in the body. Gamma interferon is a what? It's a product of the immune cascade. CD4 cells become, when they do the cascade down, they produce a gamma. The new quantiferon we have contains a section of CD8 cells as well, known as SAT6, the early secreting antigen 6, which is a portion of the mycobacterium cell, and also contains CFP 10. These are products that are included. That is why you have 4 tubes. You have a nil, a mitogen, a TB1, and a TB2. We end up measuring something different. We have a higher specificity and a higher sensitivity of it. So, if we are to combine a sputum test and a quantiferon test and interpret it in series, what are we increasing? Specificity, because we are making sure that those who are negative are truly. If we interpret it in parallel, what are we increasing? Please remember some of those concepts. Now, let's play a few games. Now, what is the accuracy of a test? The ability of a test to give the true measure of a substance being measured. An accurate test will not over or underestimate the true value. We can use sensitivity or specificity here. You know that, the game thing. If our aim is to hit the bullseye, or to hit that particular, it's called a bow or rod, and you can aim the bullseye multiple times, you're very accurate, right? If your aim is to get a 20 and you hit the 20, you're also accurate. So, now, precision relates to how consistent the results of the tests are. If you test 1,000 people for malaria using a strip that Yvonne was talking about, then it means if there is 600 people with the malaria, you really want every time you use the test to be able to get a positive test if it's positive, or a negative test if it's negative. That is precision. Repeatability and reproducibility. If every time you can hit a bullseye, you're very precise. A pictorial of it, which is always available online everywhere. Here, you are neither accurate nor precise. You're all over the place. Safi? Here, you're precise, but not accurate. You're very precise, yes, but you're not accurate. Here, you're accurate, but not very precise. Here, you're both accurate and precise. We can argue as a test for that. I took this from the OIE. How many know OIE? How many know WHO? What is the animal equivalent for WHO? Not the vets. For the other people? Wow. So I took this from there. And basically, this is how you kind of walk through validating an assay. So what Pfizer was using at ILRI was already a kit using CCHF. How many know Crimean Congo hemorrhagic fever? What is it? Hemorrhagic disease in monkeys. What? I like that. Is in camels. What else? What is that? Tick-borne disease. So, can be in human beings as well. It's a zoonotic disease. It's a viral disease. Okay, now we are good. You want to go further? Belongs to which group? It's hemorrhagic. Wait. Here, see hemorrhagic septicemia. The hemorrhagic group of diseases is one particular group. There's Ebola, and which other disease? Marburg. CCHF is in which group? When do you is that? So, there is what they call it analytical or diagnostic, but let's say analytical specificity, analytical sensitivity. So, these are characteristics of the test. Diagnostic specificity, so when you go, because this is like a lab, and then you go to kind of do diagnostic sensitivity, specificity, then you do a cutoff determination. Remember 0.3, 0.2? For them to get to 0.3 being positive, it means they had a serial dilution over time where they were able to identify what is known as LOD. What is LOD for those who work in the lab? Limit of detection. What is the minimum titer that will give you a positive? Then we select labs that are going to validate the test. So we define an evaluation panel. That is the titer we're working on. Those who work in the lab, who has ever done a checkerboard titration? Who has ever done a checkerboard titration? Where you have a new, let's say for TB, we have identified an MB8575 that is a new biomarker, a peptide, a mycobacterial peptide, and we want to basically evaluate it against a non-positive. We don't know which titer will work. So we do this checkerboard, like the checkers, right? Checkerboard, and then now we play around with it to a point where we know which ones are going to give us a particular positive, and then now we work with that to create some kind of a curve. That's the evaluation panel. Then reproducibility. If 30 labs, which is unfortunate, but if 3 labs are going to be evaluating it, then it means they're supposed to be able to produce the same, to reproduce the results. Such that if I say this is what produces a positive result, and I give it to Joy, her lab is supposed to be able to reproduce what I did for us to say. And then there's the repeatability part of it. Interpret the results and then deploy to other labs. The analytical sensitivity, analytical specificity, and the repeatability are basically the measurements together with sensitivity and diagnostic sensitivity are what is known as the measures of accuracy. Tuko The measures of accuracy contain both the sensitivity, specificity, and the repeatability. The reproducibility, which is the repeatability, are the measures of precision. We are good? So for accuracy, we can actually depend on sensitivity and specificity. And for precision, we can depend on repeatability and reproducibility. Ideally, we want to compare a new test like what Pfizer was using, an ELISA-based test, with a gold standard. Now, if I have TB in my lungs, an X-ray might be something that could be used as a gold standard. But do you think that's a good gold standard? What if it's a tumor, it's a neoplasm? What if what you're seeing there as a radiodense part is actually a tumor, not necessarily a tubercle. So you see, that will change the sensitivity of that test, right? And the specificity of that particular test. What if they're able to go in and do a biopsy and then actually show potentially either through molecular work or through staining, acid-fast staining, that this is actually Mycobacterium? Then we have some kind of a gold standard because we are assured that that's what it is, right? So we can say like a molecular test will be a gold standard. So a gold standard is an accurate test of procedure, sensitivity and specificity of 100%. Typically rare. Few gold standards exist. Gold standard samples for a negative one from animals with no potential infection or exposure to the agent, or individuals, but mainly animals, can usually be obtained from countries or zones that have eradicated or never had this disease before. The specificity of a foot and mouth disease test could be evaluated in New Zealand cattle because they don't have foot and mouth disease. Positive samples, these are from animals that have been infected, more difficult, so can be obtained from experimentally infected or vaccinated reference animals. Identify positive by isolation of the pathogen, identify positive by a gold standard. Or we can use a Bayesian model. Brian, your pet subject. So here is an example of what we have done. We have covered this from Monday. We have true positive, false negative, and true. We can calculate the diagnostic sensitivity, which is probability. Hello, hello, diagnostic sensitivity. Disease, positive given test. That is why is this over this plus. So, yeah, anyway, there they are. You can go through them later. I think we have gone through that multiple times. We have done apparent prevalence versus true prevalence. You remember that, right? True prevalence is probability of D. Apparent positive, apparent prevalence, probability of? Good one. Now, let me complicate your life a little bit. When we talk about probabilities, it's something we use, but it's because it's a way of reasoning. Eh? It's a way of reasoning that we can use to calculate certain things. Apparent prevalence is basically the probability of testing positive. So all those who tested positives, which include true and false positives, divided by the total, right? True prevalence basically is the probability of disease positive, right? That means those who are true positives and true negatives divided by total. Now, we have this classification. We can shift that and also portray it as this. You remember the formula for apparent prevalence, true prevalence from apparent prevalence? The long formula I said we are going to come back to it. Now we are coming back to it. Gari inakaribia Kericho on the way to Kisumu. Now, anything with a D, just call it sensitivity. So, and I change by day. So, test positive, disease. Okay, let me start. Disease positive, disease. Test positive, test. This is what? True. Positives is prevalence times sensitive. I'm too confused. Okay, let me just change it. You'll get confused just right now. But the DSC is basically diagnostic sensitivity. DSP is diagnostic specificity. So let's just call them sensitivity and specificity for purposes of this particular class. What's the time? Okay, so the true positives or the prevalent, the cell A is prevalence times sensitivity. So disease negative, given you tested positive, is 1 minus prevalence times 1 minus specificity. So we will come back to that later. Give yourself grace. We're just walking through a few things here. The probability of cell C, which is basically the false negatives, is prevalence times 1 minus sensitivity. This is prevalence times 1 minus, are you seeing a pattern there somewhere there? Then this is 1 minus prevalence times specificity. This is 1 minus prevalence times 1 minus. Are you seeing there's something similar to this and to this? I want you to notice patterns. Math is about patterns. So, what pattern are you seeing? We are using prevalence for disease positive, and the disease negative is 1 minus prevalence. Make sense? Makes sense? Because prevalence is probability of disease positive. So 1 minus probability of disease positive, potentially those who missed the infection, right? But then we multiply it by 1 minus specificity. This column and this column go together. This and this go together. So this is true positive. This is true positive prevalence, true negative 1 minus prevalence. So I want you to see the pattern first. Then we can go into probability. So prevalence times sensitivity. So for missing the disease is 1 minus prevalence times specificity, because it's negative, right? Those who are truly negative. So here we use sensitivity, here we use specificity. Safi? We're good? Yes. So if we increase the specificity of a test, we get more false negatives, right? We get more false negatives, right? So come back here. How do you get into false negative? So basically it's prevalence times 1 minus sensitivity. So the basic pattern here is those who have no disease, we are using specificity. So if you increase specificity to 100 means people are negative potentially. If you increase sensitivity to 100, you have all these sick individuals. So the columns positive for disease, we use sensitivity. The column negative disease, we use, and then now we put in our epidemiology hat. If 20 people out of 30 in this room had a flu, then what is the probability that X does not have a flu? Is 1 minus 20 over? Mepata hiyo? Ama ni example ngumu. So the disease positive given tested positive is probability prevalence times 1 minus times sensitivity. So disease positive given you're testing negative, or rather with the test negative, not given. So is probability 1 minus, the prevalence is the same. 1 minus sensitivity represents what? 1 minus probability of being disease positive, which is this. Sindio? Yeah. Disease negative. We are interested in specificity. The true negatives are, so we have a complete, so it's 1 minus prevalence times specificity. On this other side is the probability of not being a true negative. So 1 minus prevalence, 1 minus specificity. Then it means the potential for calculating apparent prevalence, P times DSE, makes sense? Times 1 minus P times 1 minus DSP. That is what? Please follow Hapa. Apparent prevalence is what? The probability of testing positive. The probability of testing positive is what? Is A over A plus B. In probability, we'll come to that. But here, this part is this, right? Prevalence times sensitivity. Plus. Sawa. 1 minus P, 1 minus sensitivity is this. Sawa. So what are we doing? Brian, I changed this slide last night, Sasito Siku, because of you, because you asked a question that I realized we could help others understand. So what we are doing here, okay, let me just finish up with this. True prevalence is what? Probability of testing disease positive. Sawa. I'm introducing probabilities, but with a 2 by 2 cell. And then I'll explain what we are doing. Is AP, apparent prevalence, which is this. Sawa. We already defined apparent prevalence, right? Plus DSP minus 1. Basically specificity minus 1 divided by sensitivity plus specificity minus 1. Yesterday I asked a question, and I said we are going to come back to it today. What is an independent event? In the evening at 5 p.m., when Mwema says you can go, we meet tomorrow, and you are leaving, is the probability of you leaving this room dependent on the other person's probability? No. You are independent event. So, let's go step by step. It's going to become pretty interesting very soon. What is a mutually exclusive event? Eh? At who has organized people leaving? What is a mutually exclusive event? It's an independent event. Okay, let's leave it at that to confuse what to. When you say probability of A or probability of B in a case of independent events, what does it mean? Sorry? Either one can occur irrespective of the other. In that case, do you add or do you multiply? You add. Probability of this and probability of this is probability of this plus probability of, you see where it's coming from? This is prevalence times sensitivity. These two. Nazipata. This is 1 minus prevalence times 1 minus specificity. You see where it's coming from? We are adding because they are independent events. So, let me come to this. Allow me just to finish this so that when you come back, we are doing other different stuff. I've just opened it up to the predictive value. That one we are doing apparent prevalence and true prevalence. Remember, true positive is prevalence times sensitivity. So, false positive is 1 minus prevalence times 1 minus specificity. False negative, prevalence times 1 minus sensitivity. True negative is 1 minus prevalence times specificity. For the true ones, it's the specificity for the negatives, sensitivity for the positives. And then we do 1 minus 1 minus. Positive predictive value, the probability that an animal or an individual that tested positive is in fact positive with regard to the true diagnostic status. It is true positive over true positive plus false positive. True positive, PSE, sawa, divided by true positive, that, ndio hapa, sindio? Plus, false positive. Where's the false positive? Sindio hapa. Does the formula now make sense? Hello? It makes sense now, sindio? Negative predictive value, we know it's true negative. True negatives are 1 minus P, prevalence, times specificity. We can also do that as specificity times 1 minus prevalence, there, sindio? Which is this part, mapata, divided by true negatives, repeat, sindio? Times, true negatives ndio hapa, hii part, times false negatives. Copy? P times 1 DC, what DC? And we can write that in multiple different senses. So you have that here times P. You see that? 1 minus P divided by as you move. So we are thinking from a probability perspective. And so I just added this here just to kind of, it's a repeat. An animal reacting to positive to a test has 90% chance of being infected when the PPV is 0.9. When NPV is 0.9, an animal reacting to negative has 90% chance of not being infected. The converse means 10% probability in PPV positive of a false positive. So, and 10% of a false negative in that. Predictive values are not inherent characteristics of the specific diagnostic test. Sensitivity belongs to the test. Specificity belongs to the test. Predictive values are not inherent characteristics of the test, but are a function of the sensitivity, specificity, and the local prevalence of the infection in a defined population at a given point in time. Are we clear about that? We discussed this. These are the slides I basically was trying to add in at midnight yesterday to explain. You have an outbreak of an infection, determine the epidemic, estimating patient prevalence. We have a control stage. The goal is estimate the infection prevalence, evaluation of vaccine immunity, Brayo, Kosao. Eradication stage, we are eradicating an infection, documenting freedom from disease. This is another AP concept, freedom from disease. It's a very different concept. Now, here, high prevalence, 100%, sawa, at the initial part, outbreak. Towards the end, we have a low prevalence, technically 0, but no. When false negative here, sawa, at the outbreak, when false negative missing detection are dangerous, screening assay, documenting freedom. If we miss an infection here, which means if we miss an individual through a false negative, it means we are leaving an infected or a diseased individual in the population. If we think about it here, in the 2x2 table, cell what? C is our big issue. Sawa. Choose an assay kit with a high sensitivity and a high NPV. We showed you how the positive predictive value and the negative predictive value shift even when you hold some of those stuff constant. Now, if the issue is false positive culling is dangerous at this point when you have high prevalence, we are thinking about a false positive. In this circumstance, then, we choose a high specificity and a high positive predictive value. We are good? We're just repeating concepts. It may discuss it. The other way of evaluating a test is through using a likelihood ratio. We've talked about sensitivity, we've talked about specificity, we've talked about predictive values. Likelihood ratios are alternative statistics for summarizing diagnostic accuracies. The ratio that is the likelihood that a given test results would be expected in an individual with the target condition or outcome. So, compared to the likelihood that the same individual would be expected in an individual, or that the same result would be expected in an individual without the target condition. If you find any error, Paul, it was like midnight. I was working on this. So the likelihood ratio for a positive test result, LR positive, tells you how much the odds of the disease increase when a test is positive. This is the formula. Probability of a particular test result among subjects with the disease, divided by the probability of that test among subjects without the target. I told you epidemiology is not the same as English. That test means a different thing. I took this as an example to basically show you how it works very easily. We are calculating smoking habits per year, PACs, so, with obstructive airway disease. So, we have categorized our data into more than 40, less than 40, 20 to 40, 0 to 20, and then there are some who have never smoked before, less than 1 year. So, the likelihood ratio here, we have yes, no for the disease. For 40, 42, 2. So, our likelihood ratio is 42 over 148 divided by 2 over 144. Total numbers. 42 over 2 over 144. That's the ratio. Those with the disease, those without the, those with the condition, those without the condition. Total number with the condition for less than greater than or equal to 40, 42 over divided by, without the condition, 2 over, for this other one is 25 over divided by 24 less than 1 year is 52 over that. So these are the likelihood ratios, and because they are very similar to risk ratios, we can calculate confidence intervals, and that is what you're finding here. That's clear enough for how you can use to evaluate a test. For a test with only 2 outcomes, the likelihood ratios can be calculated directly from sensitivities and specificity. So, for example, in this example here, the sensitivity was 28.4. So we can just divide 28.4 divided by 1.4. So that is what I mean by that sentence. So 28.4, which is what we were doing 42 over 148 divided by that. So here we just do 24 divided by the specificity, which is the sensitivity and specificity. The positive likelihood ratio is the proportion of obstructive airway disease who smoked more than 40 packs a year, sensitivity, divided by the proportion without the disease who smoked more than 40. So the next column, so within the same column. The negative likelihood is the opposite. Likelihood ratios can be helped to adapt the results of a study to your patients. To do this, they make use of a mathematical relationship known as Bayes' theorem that describes how a diagnostic finding changes our knowledge of the probability of abnormality. We have a prevalence that is known as a prior. So that is our assumption for what disease is in this population. At the end, we will have a test result. We can calculate another prevalence, right? There's the prevalence we assumed is in this population. That is our initial thought. At the end of a testing program, we will have a calculated prevalence, right? That becomes our posterior prevalence. So we adapt, we improve our assumptions based on that. Give me 15 minutes, and then we close this. This is where it becomes interesting. So we can also use test agreement to evaluate a test. This is mainly for categorical tests. When there are 2, we use Cohen's. When there are 3, we can use Fleiss. They're all just known as Kappa statistics. Measure of agreement, Kappa statistics, measures the agreement between 2 variables. It can also measure like rating. If I asked 3 people to rate something, 2 people to rate something, we can compare how much, like let's say they're looking through 10 papers, and we want to see what's the agreement in terms of how they're saying yes or no to the papers. We can calculate a Kappa statistics for how many times they agree. Is that clear enough? The same way with the test. How many times do 2 tests agree based on a yes and no, categorical, sawa? Not the continuous version, categorical. We can say how many times they agree. It's a single summary. Basically, it's defined as the observed minus the expected agreement divided by 1 minus expected. In epidemiology, when you see 1 minus, is a chance of not being in that particular side or cell. So remember that, missing infection, the vaccine working, or not being able to work. The way we interpret it, there's multiple ways. 0, basically no agreement. 1 is like 100%. So there's good agreement. So typically anything around 60 will be considered a good agreement between raters or test or something. Tuko sawa? Observed agreement minus expected agreement divided by 1 minus expected agreement. How do we calculate the observed agreement? A plus D over N. What is A? True positives. What is D? True negatives divided by the total. Sawa. Then we calculate the expected agreement by first calculating the expected values. How many have done? Okay, 2 by 2. So expected agreements is expected A plus expected B over N. How do we calculate expecteds? 2 by 2 table. 2 tests or 2 raters, sawa. Expected A is A plus B times A plus C divided by N. Sawa. How many have done chi-squares? Who knows a chi-square? Yeah. Have you done it by hand? Okay, good. If you've done it by hand, you understand this formula. I insist people do things by hand, kabla you go to computers and make them give you feedback. Then, expected B is A plus B times B plus D. So, over Expected C is C plus D, A plus C. This plus this plus, I see something. This plus this plus, here is this plus this plus, here is this plus this plus. That is how you calculate an expected, and you can do a chi-square test as well on that. So we get it as there. Observed agreement from our initial data is 90 plus A plus D. So 90 plus 860 over 1,000. Expected agreement of the new cells that we have calculated, 13 plus 783 over 1,000. Kappa is the difference, 0.9 observed minus expected divided by 1 minus expected. 0.755, is it a good or a bad agreement? It's a moderate, it's a good one. It's a substantial, right? It's a substantial. Sawa. We can also use a receiver operating curve. Normally, when you evaluate a test, we use sensitivity, specificity, and predictive values. However, the problem here is we have a single cutoff. Remember the Pfizer example 0.3? Let's say we can't adjust it. Then what happens? And then we also need to have a trade-off between sensitivity and specificity that is very arbitrary. And then remember that the positive predictive values are influenced by the prevalence of the disease in the population. ROC provide a graphical way of looking at a range of possible cutoffs when you're working through. So when you talk about like the checkerboard titration, we used to do that when you're doing TB, and we are looking at potentially which cutoff gives us a better positive. So it is a graphical representation of sensitivity versus 1 minus specificity, predictor or predictive false positives rate. The ROC illustrates the merit of the predictor or the predictive model, making it possible to identify different cut points for specific applications, and this depends on the cost of misclassification. Which one is more critical, having a false negative or having a false positive? You remember the discussion? Estimating the area under the curve indicates the utility of the predictor. Area of the curve of 80% is good, of 20% is bad. ROC curves plot the true positive rate, sensitivity, against the false positive rate. True positive rate is sensitivity. False positive rate is 1 minus specificity. Please look at the 2x2 table in your head and look at where the false positives are and what a false positive rate and why it's 1 minus specificity. You will realize when you calculate the cell for the true negatives, we did 1 minus prevalence times specificity. But then when we went to the cell above it, which is B, we did 1 minus prevalence times 1 minus specificity. 1 minus false positive rate. You need to integrate those things. I know it's a lot to cover within a day. Each point of the ROC represents a sensitivity specificity pair. So it looks like this. Any errors are mine. This was late night work. So when we, false positive rate is what? 1 minus specificity. True positive rate is sensitivity. So this is sensitivity and this is, so we post them against, we plot them against each other. And then we have differences. So this one in the middle here is basically a very worthless test. It's not, the more a test is, the more the curve is towards the left, the better the diagnostic value of that particular test. So when it's at 45%, 45 degrees, it's basically not a best test. The area under the curve for this, what is the area of a triangle? I have? Yeah. At base? Height. Oh, in Mesquite zingine hapo. Yeah. So it will be lower compared to that. So this is a good one. This will be a very excellent one. So when you do an ROC curve, when you're plotting that and you get one that is towards the left, the closer the curve follows the left border of the side and the top border, that, it means it has a very good accurate. The closer the curve is the 45-degree angle, diagonal, less accurate. To understand ROC, it's helpful to get a grasp of sensitivity, specificity, and predictive values We are good? See, now you have a good bug. So, Bayes' theorem. Quickly, we finish. Najua it's a lot to cover. It's a heavy class. I appreciate that. Suppose a teacher wants to know the probability that a single student, so you guys here, you are 30, sindio? So, you want to know that the probability that a single student in your class of 30 is taking either art or English. Sawa? The teacher asks the student to raise their hand if they're taking art, and they count 13. We're good? So you raise your hand, you're taking art, you're 13 of you. So sawa. Then she asked the class to raise their hands if they're taking English. 21. What is the probability that somebody in this class, we are 30, takes art? 13? 13 over 30. Are we in agreement? Hello? How many are in agreement? Raise your hand if you're in agreement. Inua mkono juu, unaogopa nini? Ama ni glucose imeisha? How many are in agreement that is 13 over 30? Okay, so when I ask you to raise your hand, if you're doing art, 13 of you raise your hand. And then English, 21 of you raise your hand. Is there people who are taking both art and English? So is that probability really 13 over 20? What can it be? I want to make the class short. What does it need to be? We have discussed probabilities. Since Monday, I'm now trying to just hammer it home why we do the calculations we do. So it will be the probability of those who take art. Our question is, what's the probability that a student takes what? Art. So it's probability of what? A. So it will be the probability of A what? So there is that. Sawa. Are we good? This is art. This is English. Sawa. We're good? Please follow the thought. I want you to realize why when you say 1 minus specificity, 1 minus what, there's a reason why it comes into that. So sawa. I'm just trying to bring this class to an end. So what is the probability of art? This is probability of art and English. Sawa. Upper katikati, you can see? So this is probability of art, this is probability of English. So if your interest is, if a student raises their hand, they are, what's the probability of art? Is the probability of art minus probability of not? Okay, probability of not taking art, right? So, probability of art or English, you end up at that. So, that is because we're assuming art is 13, English is 21. But then we are double counting, right? Already it's more than. Sindio? 33 over 30 is what? 31. Akiwa izikuwa 1 bwana. 1 point. Probabilities run from what to what? So, the teacher knows that is wrong because probabilities must be between 0 and 1, inclusive. What do you mean by inclusive? It can be 0, can also be 1. So I'm not talking about between. This is an AP class, we need to be clear. So after thinking about it, she remembers that 9 students are taking both art and English. These students raised their hand each time she counted. She counted them twice. So when we calculate probabilities, we need to be careful to count the outcomes only once. You remember the discussion about greater than 5, greater than equal to 5? That is where it comes from. Because then when you're doing that and you develop a 2x2 table, they're overlapping. There's no clear distinction between disease positive, disease negative, test positive, and Just negative. So, the addition rule for probabilities. The addition rule for probabilities basically is used when the events are connected by the word or. Probability of art or English is the probability of taking art plus the probability of taking English minus the probability of taking both. Probability of art or English is the probability of art plus the probability of minus the probability of. Make sense? Now, I asked about mutually exclusive events. Two events are mutually exclusive if they have no outcomes in common. So, are these mutually exclusive technically? They have a common one, right? So if A and B any events, then probability of A or probability of B is probability of A plus probability of B minus probability of A and. If A and B are mutually exclusive, which means the probability of A and B is 0. So they have no common event. I'm using this Venn diagram here. Then it means the probability of A or B is probability of A plus probability of. Remember when we were calculating apparent prevalence? We were multiplying prevalence times sensitivity, right? Plus, we are on this column, so it was 1 minus prevalence times 1 minus specificity. You remember that? So that when you go home and sit down, you kind of see where it's coming from. It's because they are mutually exclusive events. They don't have a common event. There's no way you'll be disease positive and disease negative. They're mutually exclusive. That is why we are doing plus. So, independent events. I asked you about independent events. Sean Paul is coming. Now, two events are independent if the occurrence of one event does not affect the probability of the occurrence of the other event. When you leave here in the evening and I don't leave, my probability of leaving is not dependent on you, or my probability of you leaving is not dependent on me. Multiplication rule for and independent events. If events A and B are independent, then the probability of A and B is probability of A times probability of B. It's no longer plus, it's the multiplication rule. Mulizifanya high school, ile tu when you're asking the question, tatumia wapi, this is the place unakuja kutumia. I'm just creating that. So let me go back here. Any events, which means they have something in common. So the Venn diagram. Probability of art is probability of art or English, or sawa. Probability of art plus probability of English minus their combined occurrence, sawa. If this is 0, then it's just probability of this plus sawa. In multiplication, if they are mutually exclusive, it will be this times. If there are any events, A or B, art or English, art plus English minus both. If they're exclusive, then these are rules. They are probability rules. Probability of A or B, probability of A plus B. Yeah, Brian? It's or. Or we double counted arts. It's the same pool, right? Those probabilities can occur. You can take English and you can take art. It doesn't mean if you take English, you can take art. So, where there? Brian, let me just repeat. There are 9 students who are taking both. You didn't see, wewe unafikiria chai. So quickly we get rid of this. So the multiplication rule, sawa. This is why when you see us multiplying and see us kind of like adding, they are coming from these rules. If the events are independent events, then probability of A and B, I'm not saying or, A and B, sawa, is A times B. An example of something called at least one rule. I'll show you how it works. The probability of A, we can say the probability of not A, sawa, or the probability of something else. Now, if an experiment is repeated 9 times, then n trials are independent. Sawa, you're flipping a coin 9 times. Safi? Those are independent events. Your first flip is not dependent on the second flip. They are independent trials, 1, 2, 3 to 9. The probability of A, event A occurring, heads, sawa, probability of A, then the probability of A occurs at least one time. You want the heads out of 9 flips. A occurs at least once in n trial is 1 minus number of trials. So these are rules I wanted to go back to the left. The example I was getting was, you know falcons, It's a raptor. The probability of seeing a falcon near the lake during the day of bird watching is 0.21. The probability of seeing is 0.21. What is the probability that a bird watcher will see a falcon at least once in 8 trips? It is 1 minus 0.2821 raised to 8. So it's 0.79 raised to power 8, 0.84. The probability of seeing a falcon at least once in 8 trips is approximately 84.8%. Make sense? Ah, yeah. And probabilities from 2-way tables. We go back to the 2-by-2 tables. They are the darling of epidemiologists. Safi? So your example here is a used car, and I would like you to translate this into disease. So I'm using a different example, but when I was thinking about it, I was trying to sleep. So you have satisfied, not satisfied. So positive, negative. So you have used car, new car, used car, positive, negative. So in terms of how we think, 92, 28, 83, 84. A person is chosen at random. Find the probability that that person bought a new car and was satisfied. Bought a new car divided by 250. So that's just one cell. So it is not new car unsatisfied, number satisfied, Safi, number of people, 250. So new used car and was not satisfied, used car not satisfied, 47 over 250. You see how we are reasoning from a probability perspective? So these are individual probabilities that we are working on. Then we will kind of combine them. Conditional probability. Is the probability that an event will occur if some other condition has already been occurred. You remember when we talked about probability of disease positive given test positive. You are disease positive given that you already test positive. Probability of test positive given your disease positive means you are testing positive given that you already have the disease. Your true condition, disease status is positive. Probability of testing positive given your disease positive is known as? I've asked the question, may flip your swali for a reason. The probability of testing positive given that your disease positive is known as positive predictive value because it's a characteristic of the test. Probability of disease positive given you have tested positive is known as sensitivity. You see where they're coming from? They are conditional probabilities. So you had disease positive, classified as disease positive, given that you already, something else has already happened. You're testing positive. You are testing positive given that you already have the disease. How well is this test measuring that you who is positive actually has the disease. Positive predictive value. You see where they're coming from? Probability reasoning. So this is probability of A given B. You read this as the probability of A given B. So, probability of testing positive given your disease positive. Probability of testing negative given your disease negative. How many play cards? How many cards are there in a deck? 50? At 54, 56. Well, watch a story, bana. How many cards are there in a deck? 52. Safi? Wachana joka. Hizo cards zote zinakuanga 52. So, this is how sometimes we do probabilities. And this is also how sometimes when you think about sampling within a population, we talk about, tomorrow we'll be talking about sampling. We talk about sampling with replacement and sampling without replacement. What do you understand by sampling with replacement? You pick if they reject, you replace. Yes. What's your name? Danson. Oh, Nelson. Okay. So you're replacing. What are you replacing? You're not affecting the total number. Sawa. So if you have 10 green balls and 10 red balls in a bucket, sampling with replacement means if you pick a ball, you bring it back. Sawa. If you pick a green ball, you count it and then you take it back. Without replacement means if you take it out, the population changes. Sawa. So 2 cards are drawn from a deck of cards. There are 52. Sindio? Or 52 without replacement. Means when you remove it, it's out. So, what is the probability that the second card is a heart, given the first card is a spade? Conditional probabilities, remember. What is the probability of testing positive given your disease positive? But here, the probability that the second card, we removed the first card, sawa. So we are left with how many? 51. So we collected spade as the first card, sawa. So the given this side is spade, sawa. So what is the probability that the second card is heart? Second card is heart, given we have already picked a what? Spade. What is the probability that this individual is disease positive, given that they already tested positive? You see the thought process? So, here, second card is a heart, given first is a spade. We know that without replacement, the first card is set aside. There are only 51 cards, of which we know 13 of those cards are hearts. So the second being a heart is 13 over 51, because we already removed the spade. So if we did not remove the spade and we were doing with replacement, let me just preempt tomorrow's lecture, it will be 13 over? Perfect. I can see it, I'm with glucose. B, what is the probability that the first card is a face card and the second card is an ace card? And, not given, and. Remember we said conditional probability is given. So, you're testing positive given your disease positive. Testing positive and disease positive. Those are two different thought processes. So, testing positive given your disease positive, or testing positive and disease positive. Those are two different thought processes. Notice that this time the question asks about both cards, both states. So, the test state and the disease state. There are 12 face cards out of 52 cards. We draw the first card. First card is a face card, second card is an ace card. We draw, we draw first card. We set the first card aside without replacement, assuming it's a face card. So, then there are 4 aces out of 51 remaining. We want to draw a face card and an ace, so multiplication. You remember? 12 over 52, because we have 12 face cards, 4 of the aces over 51, because we took it aside. So, the first one was a full deck, the second one we put it aside. So it's 48 over that, approximately 1.8. We are good up to there? You see how we are reasoning in terms of how we do the calculations? probability that one card is a heart and the other is a club. Probability of a heart and a club. There are multiple ways of thinking about it. Heart first, club second, or club first, heart. There's the OR rule. Heart first and club second, plus, because they are mutually exclusive. That is why I started that slide. They are mutually exclusive. So it's plus. We're good? You see how the rules are working? This is a 2-by-2 table that we are working with. Multiplication rule. Events A and B is A times that. Condition probability of A and B means B given A. So, B given A has happened. It means, for condition probability, it may be confusing, but walk with me a little bit here. Probability of A and B, so, divided by the probability of A. This is for multiplication and rule. This is very critical. We said satisfied and used. You remember? We were doing it as a cell. So, 92 over 250. You remember that? Hello? You remember that? But now we are saying given. Probability of disease positive given testing positive. Satisfied given they bought a used car is the probability of satisfied and used, which is 92 over, satisfied and used, 83 over 250. So, divided by probability of used, total. Safi? 150 over 250. This also gives us 83 over 250 divided by 250. That cancel. It becomes 83 over 130, which is C, notation, C over C plus. Hello, please follow up here, because itawachanganya. Please follow. We are doing probability given. It is satisfied and used. So, what does this give us? The same as our disease. This is C over. So, when we cancel everything, the 250 cancel, you know the divisions, we end up with 83 over 130. That is 83 over, which is the same as C over C plus D. What is C over C plus D? What is C over C plus D? On Monday, let's start from Monday. That was what? The rate of disease in the unexposed. This is how it's a combination. In probability terms, what will this be? In probability terms, is the probability What is positive predictive value negative? Of disease Now, let's get slowly. What is the probability of being disease negative given you tested negative? Okay, what is the probability of testing negative given your disease negative? That is the negative predictive value. What is the probability of being disease negative given you tested negative? So what is C over C plus D? Is the probability of? In the test side. Disease negative given. Are Are we clear? Sorry? Huh? Sorry. Confusing that. Okay, let's go back to the slide a little bit. So I'm sharing this so that you see how the probabilities are working. When we say A over this plus this, probability of this given this. So, we are clear with that? So, to finish up, I will not go through this. You will go through this on your own time. These are the probability formulas. Where intersection works, Madam Intersection, hello. Where union works, Akina Brayo, where they want, you go through this. But focus on the conditional probability here, where probability of A given B is the probability of A and B divided by the probability of B. Probability of A and B is what? Remember the Venn diagram. This is your first thought process. Start from what you know to what you don't know. Probability of A and B is intersection point. Is the probability of A times the probability of B given A, the same, divided by the probability of B. We can interpret that in a Bayes way. So, the probability of A given B, please watch this because this is my last slide and then the rest I'll just graze through and then we go. The probability of A given B, remember the 2 by 2 table, so, is the probability of B given A, the probability of B given that A has happened times the probability of A, so, divided by the probability of B. Conversely, the probability of B given A is the probability of A given B times the probability of, divided by the probability of, that is the Bayes theorem. You can prove it later in your house when you're sitting down or on a weekend when you want to rest and just watch the skies. It will be a good one. But it's a good thing to remember that. So, it's a very simple formula that helps us do a lot of stuff. So, I'll walk you through this, then we close. A given B is B given A times A. B given A times A divided by, can be derived for events random separately. This is the thought process. A given B is A and B divided by B, where P is not equal to, B is not equal to 0. The probability is not equal to 0. So, B given A is B and A divided by A, P of A, where is not that. Here, the joint probability A and B of both events, A and B being true, such that B and A is equals to A and B. We clear that out. So in other words, B given A and B times B, B A times A. So A and B is B given A times A divided by B. Make sense now? You can follow it up, but it can be used to determine the accuracy of a medical test results by taking into consideration how likely any given person is to have the disease and the general accuracy of the test. It incorporates a prior probability and the posterior probabilities. Prior probability is the prevalence. So, the posterior probability is what we get after we do the test, and we can calculate a new prevalence. Then we update our information. We are updating our information kwa nini? Because we are given a prior times the probability B7. So in other words, if we have the sensitivity, the specificity, and we have some cell information, we can calculate certain aspects. We use that to develop certain thought processes around that. And then the final one, basically, we can use the Bayesian extension. That's called a Bayes theorem. It's called the Bayesian. Bayesian statistics are different from frequentist statistics. Please go check on that. I'm not going to cover that. We can have infection status that are unobserved, because the problem is when we do, we can combine results from multiple diagnostic tests, especially in the absence of a gold standard. So we have two different standards. So in other words, we don't actually know the true prevalence within that particular population. And sometimes we want to kind of update our information about what's the true prevalence, what's the specificity and the sensitivity and the positive predictive values if possible. Instead of individuals being explicitly classified into infected or infected, each individual is assumed to have a probability of infection, given the combination, given probability. So the combination of diagnostic test outcome, knowledge of the accuracy of the test used, sensitivity and specificity, and prior knowledge of the disease prevalence in the population of interest. In other words, prior information about the variables to be estimated, sensitivity, specificity, is combined with observed data, the results we get. So, to obtain a posterior distribution of the variable, which is then updated belief of the variable's true value. Thus, knowledge of the true disease status of the sampled individuals is not required to inform measures of test accuracy, prevalence, population of interest. I sent you guys a paper. This is just a repeat of what I've said. In statistical terms, the posterior probability is the probability of event A occurring given that B has occurred. So, probability of A given B is probability of B given A times probability of A divided by the probability of B. B given A is the posterior probability. You can go through that. We will go through the code, and I can come back to this. So, we have a code that we can go through. So, Sangape, I know I've really spent a lot, but I really just needed to get rid of that so that when we start, we can play around with the yesterday's code, and then we will come back to today's code as we move. And then we can continue the yesterday's code to tomorrow. We were working with some data sets that Ngetich sent me that we can do a different one. So let's go take a break, and then we can come. Moema, take over.